where we have seen data that shows that up to 75% of our patients post-surgically that die in hospital have never been to ICU at any stage. We've also seen that almost half of the adverse events that occur in hospital occur in the general ward. And when it does occur, it's responsible for a high proportion of the mortality. Over the last few decades, a lot of research and innovation has gone to reduce the intraoperative mortality. So our patients are not dying in theater for elective surgical cases. They're not dying in ICU. So the problem lies beyond the ICU. The code blue does not occur out of the blue. We know that up to 4 hours before a cardiorespiratory arrest, a lot of our patients will start displaying abnormal vital signs. And the increasing number of abnormal vital signs, the higher the likelihood of complications like mortality occurring. This is a scenario comparing two monitoring strategies. The one on the left is intermittent spot checks, which occur in hospitals all around the world. At 4 o'clock in the morning, the patient is lying comfortable in bed. At 4:40, they begin to deteriorate and they have a hypoxic event. It's not until the nurse or the healthcare assistant passes by, maybe bringing in their breakfast, that they identify that something's not quite right. They then go back, bring their OBS machine, monitor the vital signs, allow it to update into the electronic health record, which will then calculate the early warning score, and then based on the threshold, can alert the physicians to intervene. By this point, usually it's too late. When you sit on morbidity and mortality meetings in hospital, this happens more frequently than we like to admit. On the right is the perfect world, the situation where our patient is now wearing a continuous vital signs monitor. When the patient begins to deteriorate and the monitor detects that, it highlights that to the healthcare team in a closed loop fashion, alerting them whereby they can intervene much earlier and avoid a full-blown adverse event. But there remain several other challenges. We know that the respiratory rate is the strongest predictor of clinical deterioration. And as you can see on the graph there, where we have the area under the curve, respiratory rate has a higher sensitivity than heart rate and blood pressure in detecting patient deterioration. Unfortunately, it's also the vital sign that is most inaccurate in our systems, likely due to the cumbersome method in which, the technique in which we have to monitor it, standing by the patient's bedside, looking at chest exertions for about a minute. Lots of surveys and data has shown that it's estimated, and it tends to average between 12 and 16. As you can see here on the right, the yellow dots represent the respiratory rate taken from the electronic health record, which again here average between 12 and 16, and there might be one or two that are 18, culminating with the bar on the right where the patient has deteriorated to the point they require transfer to the intensive care unit. This patient had a continuous vital signs monitor on as part of a study that was blinded, and you can see the upward trend of that red bar from the continuous vital sign monitor, which is monitoring their respiratory rate. Now, if such trends could be identified early, we could potentially reduce and avoid adverse events and transfer to intensive care units. But we also face system challenges, which are exacerbated by the pandemic. And as you can see here in the burnout surveys, you can see they cite staffing shortages, excessive workloads, and rigid schedules as key issues. Our patients on the ward are also older patients with complex issues. There are multiple comorbids, polypharmacy. Our organizations are very reliant on track and trigger systems like early warning scores as well. And we have to think about how we can ensure equitable care for diverse populations. So clearly there's a need to do something different. And we think the answer is continuous vital signs monitoring. which offer the promise of allowing our patients to be more mobile on the ward while they're being monitored. This allows them to engage with physiotherapy. They can go off the ward and have their scans done in radiology, and they can walk and meet their relatives outside. We encourage this because we know patients that are mobile post-operatively have a shorter length of stay and a faster recovery. Continuous vital signs monitoring also has more accurate vital sign detection with respiratory rate. And these are usually validated against capnography to be fairly accurate. They provide our clinicians with real-time data where they can intervene much earlier, reducing adverse events. Now, I have up there challenges, but I think I should change that to opportunities, because this is where data lacks in the research community, and we are trying to fill this now. At Chelsea and Westminster, we're doing work to understand better what alert parameters we should set for continuous vital signs monitors. How do we reduce false positive alarms and clinically non-relevant alarms? We're also trying to understand how to integrate this new technology into existing wards and systems. And the question which we set out to answer was, what's the cost-benefit analysis, where we can compare a continuous vital sign monitor with intermittent monitoring in post-surgical patients. We wanted to look at two different healthcare settings, one in the UK and the other in Netherlands. And we looked at three outcome metrics. We looked at cost savings, we looked at resources saved, and we looked at the environmental impact. The data we got from the UK was from our federated data platform at Chelsea and Westminster Hospital, where the federated data platform in Chelsea and Westminster Hospital, where we have high-level aggregate data of every patient that was admitted within 1 calendar year. We had data on their complications, their transfer outside of the general ward, and the costs associated with these patients. From the Netherlands, there was a lack of this data, but we extrapolated this from peer-reviewed data, literature. So we developed a decision tree model, and we simulated the clinical trajectory of the hypothetical cohort of 100 patients under two monitoring strategies: the continuous monitoring arm and the standard of care intermittent spot checks. We tracked patients for 30 days from the time they leave the theatre until the 30 days after discharge, and we're looking at readmission within that time. Potential events which we looked at were either no complications, a rapid response team activation, ICU transfer, 30-day readmission, or death. Clinical probabilities and associated costs were retrieved from peer-reviewed data literature, expert consultation, and institutional data sets. We attached transitional probabilities to each branch, where we reflected the likelihood of a patient moving down each pathway. Importantly, the control arm followed an identical structure to the continuous monitoring arm, and this allowed for direct comparative analysis. These were some of the model inputs which went into the decision tree model. We looked at in-hospital cardiac arrest, heart failure, and acute kidney injury as potential complications. The results were compelling, and we're going to walk through them in three different graphs, looking at costs initially. The data in blue is data from the UK, in orange from Netherlands. And the darker shade reflects our current standard of care, intermittent monitoring. The lighter shade reflects continuous monitoring, which is what we are looking at. If we go to the far left, we can see that the total cost per 100 post-surgical patients in the UK with intermittent monitoring is £775,000, and this reduces with continuous vital signs monitoring to £661,000. In the Netherlands, that reflects £686,000 down to £577,000, translating to a cost savings of over £100,000 per 100 patients. As we move rightwards through the chart, we have broken down these costs into various categories. We can see that the dominant cost driver in both countries is ward stay without ICU transfer. Although the cost savings here are small, they reflect that shorter length of stay is driven by earlier detection of deterioration. What's particularly striking is the fourth set of bars, which looks at ICU stay. There's a reduction here of approximately 40% of ICU-related costs. The same holds true for readmissions, rapid response team activations, and adverse event treatment, all of which show a benefit with continuous monitoring. Although these contribute a smaller amount to the total, they still reinforce the narrative that continuous monitoring helps detect complications early and reduces resource-intensive interventions. So we're not only showing a reduction in financial impact over here, we're showing an improvement in operational efficiency across different setup in the wards. When we look at the resources saved, there's a clear reduction with continuous monitoring here as well. On the far right, we show a reduction in the rapid response team activations by almost half in both healthcare settings. The total number of medical surgical unit days, which is the length of stay in the general wards, is also reduced by approximately 20 to 30 days. The total number of ICU days as well is reduced by about 19. So this tells us that not only are fewer patients being transferred to higher level care when they're continuously monitored, but when they do go to higher level care, they spend a shorter time there. The total number of readmission days is also reduced. I attended a talk yesterday where we were discussing environmental impact of healthcare, and they did a Slido survey of the crowd, and we underestimated the contribution of healthcare to the carbon footprint of the world. And we demonstrate here that there is a benefit with continuous monitoring in both healthcare settings in the UK and Netherlands, with a reduction of CO2 and waste generation. Now, although these results appear to be quite modest, when extrapolated over a national healthcare setting, these savings become more meaningful. More importantly, we achieve this without compromising clinical care for our patients. So, in summary, we demonstrated that with continuous vital sign monitoring in our general wards for post-surgical patients, there's a reduction of transfer to ICU, and when they are transferred, they spend fewer days in higher level care. We also showed that there's a reduction in admissions, in readmissions, and in mortality. What these two parameters show is that there's an improvement that translates to significant cost savings and environmental benefits as well. A few limitations, and the first one is a limitation of a decision tree model as a whole, that a patient can only have one adverse event. We also assumed that a readmission is to a general ward and not to an ICU. This is due to lack of data on this parameter. We don't include device implementation costs in healthcare analysis models like this because there's variation between partnerships between providers and healthcare systems. And our results were based partly on high-level aggregate data and partly on literature review. In conclusion, we can say that continuous vital signs monitoring is clinically effective and economically advantageous, yet it's environmentally sustainable. The findings of this study are robust enough to merit serious policy and procurement consideration. And as always, further studies will only validate these findings and support widespread adoption. Thank you.